we really have to start the quiz right away. So, does anybody know where anybody is? No? All right, well, unfortunately, I have to start the quiz, so you guys are lucky that you're here on time. I'm hoping there was no confusion with the other Zoom, maybe from last week, but that was only for 1 week. Does anybody see someone that they is not? Oh, here's one more. All right, well, hopefully everybody joins. We're going to start a quiz. Mercy, I need your camera on, please. Please unblur your background. If you have a blurred, Ambria, you have a blurred, Mahogany, you have a blurred. Let's see who else has a, everybody else looks fine. First and last names are in there. All right, so we're gonna get the quiz. I don't publish the quiz until we start class. So if you haven't been able to download it probably, but let me just publish it now and then we should be good to go. Any last minute questions before we start the quiz? No? Okay, remember, if you guys aren't here on time, then we can't redo the quizzes. So just remember, really good work being here on time. I'm happy to see all of you. Okay. Quiz number 2 is now published. Okay, so what I want you guys to do is see if you can open your quiz under module week 3.
Mine says it was locked. Is that
Okay.
right?
So it might have been locked. I published it. So if it's still saying, is anyone able to access the quiz? It's going to ask for a passcode.
I'm not seeing. Let me go back out and redo it.
Okay.
Let's make an ice cube table because my cubes are always too hot.
I don't see it at all.
Yeah, it
don't
should be
see it at
under modules. It should be under module 3, quiz 2.
This together. Wait.
Yeah, mine is still saying. It just says
Locked.
this quiz was locked October 22nd at 4:30 p.m.
Okay, so I'm going to change the time and then you guys should be able to access it. Thank you for the feedback.
Okay.
Yeah, mine's saying the same thing. It says this quiz was locked October 22nd at 4:30.
All right, so I'm gonna let me do this. All right, do me a favor. I've just updated it. I want everybody to refresh your screen and see if that goes through this time. It's going to ask you for a passcode.
Okay, it's working now.
Great. Okay, you guys ready for the passcode? All right, it's going to be capital S-U, the word sunny, capital S-U-N-N-Y 56.
You said the letter U and then Sunny.
No, I'll put it in the chat, okay? Just try not to, if you have a question, just raise your hand during the quiz, okay? And we'll come back like at, like 4, which is like 6, your guys' time, because it'll give us about 15 minutes to take it. Oh, no. Come back around, 50 after the hour. About 15 minutes from now.
My canvas is frozen, so I haven't been able to start.
Cheyenne, I need your camera on. Your camera is off. I won't be able to take your quiz score unless your camera is on, please. Alrighty, guys, everybody should be done with their quizzes, so come on back to camera. We're gonna start our lecture for tonight. And just a reminder, you can't be in the car, you can't be talking to people. Natalie, text her and tell her I sent her a message. She needs to see the message there. What else? We're just waiting for one other. Okay, so you guys took the quiz. How many thought it was hard? Nobody? All right.
I just didn't know what it was on, so I wasn't
Thought it
prepared.
was difficult. Okay, so the quizzes are always going to be the same. They're going to be on the material we covered the week before and the material that you're ready for this week. Okay, so like next week we have a test, so we're not going to have a quiz. But then that next week it'll be on week numbers 4 and 5 together. Okay. I wanted to go over the practice exam and exemplify. Everybody has to do that before our test. Dr. Brown said if it is not done, we will not take any time to do corrections and exemplify. So please make sure you do it. The password is 4-0-1. Okay. What else? You guys had your discussions. I graded those. Just a friendly reminder to everybody on our discussions, please don't use AI to write your discussions. The problem with AI, it's good like for lots of things, but it's bad for like writing pieces, right? So just be careful if you think you're doing something that might be AI, I would really try to stay away from it because we don't accept that at Fortis, okay? So make sure that you guys are writing, add your own brain, your own mind, all that good stuff. We have our exam next week. Exam reviews are this week, so please try to attend them, okay? We're gonna take a look at one concept. Tonight is really about labor and delivery, which is like, you know, my forte. I love it. Did it for 12 years. In a supervisory position for about 7. So I know I can share a lot about it. And any questions you guys have. How many have started clinical? Good. What did you guys think of clinical? Did you guys do labor and delivery yet?
And,
Sorry, just one second.
and in Fortis Cutler Bay, we only have one maternity clinical.
Oh, that stinks. So you don't really get to see anything.
Yeah, we
Right?
have three.
No, but we have an we have on campus sim like every
Simulators?
Monday. Yeah.
Oh, yeah.
For maternity.
That's not the same though. But it's cool that you have that because at least you have something, right? But those that get to see it firsthand, like it's really a cool, spectacular experience. And if you've had a child, like, you're coming from the other side, so you've never been the nurse on that. But I can tell you just from being a labor and delivery nurse, I have had patients come up to me like in random places. I was on the boardwalk with my family, and some man came up to me with a toddler. And he just looked at my husband. He said, she's the most amazing woman in the world. And my husband like looks at him, like, what's he talking about? He said, she delivered my son. And he remembered, I mean, I didn't remember him. I've delivered over 1,000 babies, but the impact a labor and delivery nurse has on those parents is remarkable. And so you're never forgotten. And it's a fantastic field. Is there anybody that's interested in going into labor and delivery? Yeah, just one of us. Well, good. I'm glad.
I think that I might be because I'm in labor and delivery. Like I just did labor and delivery over last Friday. This Friday I don't know where I'm going to be placed, but the first time I was placed postpartum, and now this time I was placed in labor. I did 2 Foleys and
Good. See, so that kind of stuff. What are some advantages you saw or could think of with labor and delivery nurses that are very different than other kinds of nurses? Anything that you've seen?
So far, I know, like, first of all, the placing of the Foley is very, very, very important in there, for several different reasons. Not just because, of course, you want to get it right, but you have a fetus to think about as well. So it's not like you're just putting a Foley in there. You have to make sure that it's not clamped off. The urinary tube is not clamped off or anything like that. Like, it's not being pushed off.
Good, and
I would
remember
say the
your
other thing.
anatomy. Remember your bladder
Mhm.
is right above. So
Yeah,
if that's full, imagine what that does to the uterus, right?
yeah.
Very good. And catheters, as a labor and delivery nurse, I can tell you, you could do them almost with your eyes closed if you're a labor and delivery nurse, because you do so many of them. And it's
So
all the same
many.
anatomy because it's all females, right? So once you get good at it,
Mhm.
you're like good at it. It's one of those things, kind of like IV sticks. Good. So Foley's are really important. You're caring for a baby and a mom. That's like really cool, right? And think about the autonomy though that goes into a labor and delivery nurse. So anybody who has been on the floor, your patient to nurse ratio is usually less than 2 to 1. So you're going to either have 1 or 2 patients at all times. You're not going to have more than that. Why do you think that is? Why do they keep that ratio so low?
Because you have to give your patient a lot of attention, because it's not just one patient. It could be two, three, depending on however many babies they have.
Good.
And the
And you're going to
process,
be watching those fetal heart strips. That's a whole chapter that we have this week. You're going to be watching those non-stop. What do the fetal heart strips tell us about the baby?
The ascending and descending heart rate.
Yep. And what that tells us, are they getting oxygen or are they not?
No.
Okay. On a telemetry floor, you're going to have EKGs running all the time, right? But those are live people that are talking, can tell you I don't feel good, or can push a call button, right? When you're looking at fetal heart strips, that baby cannot call you and say, hey, I need help in here, right? So I want you to really think about that. It's an autonomous position. And anyone who's ever worked in the field or knows about it knows that the nurse is the primary healthcare provider. The doctors come in for the delivery. The nurses do everything up till then. So the nurses watch the strip for their whole shift. The nurses care for the patient. They put the Foleys in. They put the scalp electrodes in. They do monitoring. They watch the fetal heart rate. Their job is then to call the doctor if there's a problem, right? But the doctors, a lot of the doctors will be home when their patients come in if they're in the early labor. So it's totally up to the nurse. The nurse is the one in charge completely. And so there is liability, obviously, because of nobody ever wants a baby that's not great, So that's why. But there's a lot of lawsuits that go on in this industry. Not always one. They're not always one. But think about it, as a parent, you never want anything wrong with your kid. And so what parents look at is what has happened up until the point where they see a deficit, right? So could have been the labor process. That baby strip can be pulled for 7 years and looked at. So think about that. And if you work in healthcare, and I work in a school now, it's interesting to see when I work on reports where those babies came from, right? So the history of their prenatal history is significant in how they turn out developmentally oftentimes. So it's really monumental. The thing I wanted us to look at tonight, and it was on your quiz, so hopefully you guys knew it. But it's a very important concept, and you guys might have gone over this last week. I know you had a sub in for me, so you might have gone over this last week, but I'm going to go over it with you myself because I want to make sure that everybody understands this. It's like a mnemonic, It's how when we see a patient, we can figure out what's going on with them. Okay. So if you look at this is one of your handouts that's available for you guys. So it's called GTPAL, right? So we do gravida, which is how many times pregnant. Then we do term, preterm, abortions. Now remember, abortions could be terminations or not intentional terminations, and then living. Okay. So our parity is those that are delivered after 20 weeks. Okay. And so we want to look at that. Why is that important, do you think? Why do we care? We don't? I hope we do. Mahogany, turn your camera on. Kelly, turn your camera on, please. Why is this important? What piece of our nursing process is this?
What's the question again?
What part of the nursing process is this? Figuring this out about a patient.
Not, isn't it from the beginning assessment when you're finding
Very
out?
good. Yes. Keep going.
Next person.
It's an intake. It's your admission. It's easy. It's quick. This tells us in 5 questions, 1 mnemonic, right? So you can just chart that and that's easy. So when you look at a board in a labor room, a lot of times they'll have the patient say maybe their initials, then they'll have G6P1. Why do you think that matters? If somebody has never had a baby or has had 5 babies or has had 6 sets of twins. Why do you think that matters? As a labor and delivery nurse.
Well, probably affects the outcome, no?
In what way?
Or like, well, I guess at what point are we looking at this? While they're like they're giving birth or in the
Yep,
beginning?
they're in the labor room. Yep.
Maybe complications with their uterus or something like that. I know.
Good. If they've had a lot of babies, absolutely.
It's
Their
like
uterus is a
or
muscle, so
something.
it's stretched and stretched and stretched and stretched, might not go back. What else do we know about this?
I know it's the same with C-sections. Like you can't have too many because
Mhm.
it's the same thing, risk.
Yeah, but we don't know here if they're vaginal or if they're C-sections,
Yeah,
right?
that's true.
We just know that they've had this many. What happens on a labor and delivery patient who's a first baby versus one who's a third baby? Do you guys know?
Doesn't it come faster if it's your third?
Exactly. Yep. The more you have, the quicker they come.
Mhm.
Is the rule of thumb. Now, there's lots of reasons why babies don't come. So if you're having your second baby and the baby's taking forever, that happens, right? But what we have to remember is rule of thumb is first baby takes the longest, and then those babies following will. So when you're in labor and you see like it's a gravida 1, you're like, oh, this is the first time pregnant. They've never had anything. Could be a gravida 2 para 0, which a gravida 2 para 0 means how many kids do they have at home?
They don't have
Right.
any, right?
Right. Their para is how many they have at home that are alive, right? So what if you have a gravida 1 para 3? What does that tell you?
That she's had 3 kids.
Okay, but she's only been pregnant 1 time. So what's that tell you about the kids?
Oh,
Triplets.
Yeah,
yeah.
they're triplets, right? So we could have a gravida 4 para 7, pregnant 4 times, has 7 children coming out of that. So she's had twins or triplets or something along the way, right? So we can always know that. So I'm going to show you a couple examples. We're going to do these together. I want everybody participating because I have a feeling I've noticed with this class, you guys are really quiet. And so that's fine. But what we're going to do is I'm going to give you an example. Kelly, your camera is still off. If it doesn't come back on, I have to put you in the waiting room. I can't have you here for attendance. Okay, so I'm going to give you a couple examples. And what I want you guys to do is do it in your head, figure it out, and then you're going to put your answers in the chat. Okay? That way I know everybody's not sleeping. All right, so I'll show you my examples. Just 1 second. Okay. Oop. Okay, here we go. Here's our first one. 28-year-old woman just delivered a term. She's a 3-year-old daughter who delivered past her due date. And last year she had a miscarriage at 8 weeks gestation. How would you note this history using the GTPAL system? So I want you to do that first one and put your answers in the chat. So how it would look is GTPAL, or you could just do G and P, whatever you feel more comfortable. But I really want you to understand this concept because this is pretty important. Just the first lady, the 28-year-old. So we're writing our answers in the chat here. Let's see. All right, we got 3. We got a bunch here, so here's another good one. All right, what you'll see is you're never going to see the numbers like this. I know what you guys mean because I told you could do that, but you'll never see it written that way. The way you'll see it written here, can everyone see the chat? It'll always be capital G. All right, so let's figure out how many times has she been pregnant, this lady? She just had one, that's 1. She has a 3-year-old, that's 2. And she had a last miscarriage at 6 weeks, so that's 3 times. So she's been pregnant G3. And then how many did she have living?
2.
Good. So it'd be G3P2. Okay, that's how you traditionally see it. If you use the whole entire thing, it's going to be G. Oopsie. Come on. It'll be G3. How many at term did she have? How many did she have full term? You guys want to see it again? How many did she have full term?
2.
Okay, you say that, but you question it. You're right. What 2 did she have at per term? And how do you know that?
She had the 3-year-old past her due
3-year-old.
date, and then she just had one she delivered to term.
Yeah.
Excellent. Excellent. Perfect. So she has 2 at term. Does she have any pretermers?
Yeah, wait, no.
No. Yeah.
No.
Pretermers would be
Right.
past, would be preterm, so they survived. Okay, so does anyone know what gestational week you have to survive at? How many weeks do you have to be in order to be what's called viable with life?
30.
No, way before that.
Is it 24 weeks?
25, no?
You guys are close. So depending on the state you live in, it's either 23 and 5 days or 24. Because that's when, you know what is developed at that point, but not enough to survive. They always need usually some steroids. What body part you think is developed by that point?
No.
Their lungs?
Their lungs are able to survive in the real world. That's true. That's it. Really. Their brains are developing. their heart is developing, but their lungs are able to actually take in air and excrete air. So 23 and 5 to 24. All right. So anyway, preterm, and then she had one termination. So that's an abortion, even though it might be a miscarriage, right? We still call it A. So it would be A0. I'm sorry, A1. And then how many does she have living?
2.
2. Okay, so it could be written either this way or this way. All right, I'll put that in. Oh, why does it go? Oh, you guys can't see this, can you? Sorry. Okay, here. It's in the group chat. All right, now we're gonna do this next question. It'll be very curious. Your prima gravida patient comes for her 40-week prenatal visit. How would you note her obstetric history using the GTPAL system? So you guys have to know a certain word in here and what that's going to mean. So let's see if anyone gets it.
The prima gravida, which means this is our first pregnancy.
Very good. You're sharing with the group. I love it. So this is first. Prima means she's a prime, is what we call it sometimes. So a prime means first pregnant. Or okay. So how are we going to write this using this GTPAL system? Just do it in the chat again.
Capital G.
Good. It would be G1, but what else are we going to put there? It's always given. So it's G1. Good. I like that, Desiree. You were very thorough. Excellent. Everybody see Desiree? She did G1, T0, P0, A0, L0. So sometimes, good. Cheyenne also put para 0. So it's always going to be a gravida and a para. So para would be a P0. Okay. And this we can put on our admission assessment, right? So that's an easy way to do it. And so you guys know it. You're going to see this. So I want you to know this lingo. Okay. So it's gravida, how many times? Term, preterm, aborted, and living. Okay. So very important to remember. All right. Let's do one more practice question. Okay.
I actually have a question.
Go ahead.
Normally, P, wouldn't it be preterm? Or like normally would you just put the gravida and para, and then if you want the whole thing, you would put the GTPAL?
Yeah, so if you see G1P0, that's gravida para, which means pregnant, delivered. Okay? But if you see the whole thing, GTPAL, that's where you're going to get the preterm. That does get a little confusing. I appreciate you pointing that out to me. So we're just traditionally when you're doing an assessment, an intake, you're traditionally just going to really care about how many times pregnant and how many outcomes, right? Because that's going to change your plan of care as a labor and delivery nurse. But let's look at this one here. This is an example, and you guys just pick A, B, C, or D. Sorry, we're just going to the tippy top. All right, we're getting a lot of C's here. Okay, so let's look at the question here. Okay, a pregnant client, I want you guys to count with me, is making her first antepartum visit, which means what? What does antepartum mean?
Before birth.
Yep. She has a 2-year-old son. That's one pregnancy, born at 40 weeks. A 5-year-old daughter. That's what number pregnancy?
Well, I started at the pregnant client. That started with 1.
Interesting. Okay. You're right. If she's pregnant. Yeah, okay. So if you want to start that way, that's an interesting way to perceive this. That's not how I read the question, but you are correct then. You guys are correct. It would be G5 if that's the case. Because she's got a 2-year-old, she's got a 5-year-old, she's got a 7-year-old, she's got twins. I mean, sorry, she had an abortion and she's pregnant currently. So she'd be a G5. Good. And then she has a 2-year-old at 40 weeks and a 5-year-old at 38 weeks. So how many term pregnancies?
2.
Good. And then she had twins at 35 weeks. That's preterm. So how many did she have preterm?
Oh.
1 pregnancy that was preterm, right? And then she has 4 living kids. Okay, so you guys were right with your answer for C. Okay, I would have done it a little differently, but that's okay. You guys are fine in the way you did it. Okay, so any confusion at all on this system? No? We're good? All right, so what I want you to think about is that importance. Sorry, I have to put somebody in the waiting room because our camera hasn't come on. Okay, so what else can we do here? Okay, now we're going to look. So we got that covered pretty good. And so I'm not worried about that. That was on your quiz. Did everybody do okay on that one? Or iffy? We're going to do a little PowerPoint that is out there for you guys. You have it in your announcements. We're going to go over it a little bit and we're going to then do an activity together where you guys figure stuff out. But for the first part, we're going to just talk a little bit about the labor and delivery process and what that goes into. Sorry, just give me 1 second. I'm pulling it up for us. So all this stuff that we're covering is going to be on our test, okay? So we have to be really comfortable with all that we go through here. All right, so on our first slide, your book talks about, and you guys should be familiar with the powers of labor, the 4 P's of labor and delivery, right? The powers, the passenger, the psych, and the process. Okay, so those are 4 main things. When we look at our presentation, that's another one in position. All right, so we're going to take a look here. Our powers, when we talk about the powers of labor, we talk about those contractions that come. Okay, so it's a tightening of the muscle. And so in order to have labor, you have to have the uterine contract, right? They're coordinated, or they're involuntary, or they're intermittent. Okay. And then the next power we look at is the mother, because the mother has to be able to push a baby out. What kind of medical conditions would not allow a mother to push a baby out? Think, what can you think of that somebody might have that wouldn't allow them to push a baby? What kind of...
Would it be an STD?
Well, they could still push though. So what I'm really trying to have you guys think about is what would be a condition where their muscles couldn't really tolerate that.
Go up your paw.
Any ideas?
Maybe like a spinal cord injury or something. I don't know.
Excellent. Spinal cord injury where they don't have the feeling. Any type of dystrophy, right? Where they don't have the muscle control. There's some conditions where they'll have like a weak pelvic floor, so they have to do exercises when they're not pregnant in order to have them be able to push out a baby. So there's a lot of things I want you guys to think about there. Our next thing we look at is the passage. So there's several different types of pelvic types. So when you look at the pictures, they're kind of self-explanatory. So one looks like a heart, and then one looks like a circle. One looks like an oval, and one kind of looks like a heart without a bottom. Does everybody see that? So why do you think that matters? Why does it matter what bones you have in your pelvis?
Well, I know some make it, I guess, more difficult to push a baby out.
Yeah,
No?
think about
But they'll,
why.
like, maybe because of space.
No, they're gonna have
or-
less area, right? Less area. So
Mhm.
if you have a circle or you have an oblong and you have a round head coming out, could you see why, like this one, your platyploid is going to be difficult because you have that bone sticking down here. So you have to push past that bone. Not impossible, but just think about also your dimensions of the pelvis, because that's really going to make a difference if the baby can fit through. Then we have the passenger. That's our fetus, right? So we have to figure out, how do they lay? What are different ways that babies can lay in the uterus?
all over the place, honestly.
Exactly. You're 100% right. Exactly. They can lay however they fit. So it depends on how they're laying. Now, if you have a baby whose butt is laying downward, right, and their head is up, it's going to be impossible to push out a head because you got to get past the butt, right? So when you're thinking about that, you got to determine, like, are they something that's called breech, which is upside down? Are they a shoulder presentation? Is their shoulder presenting and not their head? So you're not going to be able to push a baby out. Think about how much wider your shoulders are than your head, right? What do you think about gestational age? Why would that matter?
The size of the baby.
Excellent. So if a baby is 25 gestational weeks and a baby is 35 gestational weeks, who's going to be bigger?
The 35.
Yeah, the bigger, yep, the bigger the older they are, the more developed they'll be. Muscle tone, okay, of the baby and the size of the baby. So sometimes babies just grow really big and they're too big for their mothers. This fluid starts leaking.
I wasn't able to hear you.
Yeah, I was just gonna say that cut off.
Yeah,
I
I
don't know
went,
if
I
it's just
went
me.
unstable. I don't know why my internet, which is
Oh,
weird, but
all I heard was
what happens
fluid.
if you get leaking of this fluid that protects the baby? What do you think happens? What happens if this ruptures? So that any of this fluid that's keeping the baby safe in here, this amniotic fluid, what do you think is going to happen?
Wouldn't that be an emergency?
So it's not necessarily an emergency, but think about what happens. So now I have this baby, it's in this nice sac with this with these membranes, and then the membranes break. What does that allow for to occur?
Oh, the
Now I have
feces.
a break in the balloon is how I like to think of it.
The baby can be in the feces, in the urine.
Yes, but that's okay, even if they break the membranes. But think about what happens when you have a balloon if you put a little hole in it, not a hole that'll pop it, just a little hole. What happens to all that air that's in
Yeah,
the balloon?
I was gonna say, don't they breathe in there with the fluid? Like that's where they're getting oxygen, or no,
Well,
not
they actually
necessarily?
breathe through the placenta, but
Okay.
the membranes, what I want you to think about is what happens if they're in this wet sac, right? Why do you think they're in a wet sac? Why do you think that's the way anatomy has created it? What do you think that wetness does for the baby?
Protection.
Yeah, good. Protection. And it gives it fluidness, right? So that the baby can move. Because imagine if it were in there with no fluid, the baby would be stuck in one spot, right? So what ends up happening is when you have a break in those membranes, it's an avenue for infection because there's like a little hole, like in a balloon. And so now bacteria can get up there and get into the baby. Okay. So just think about that. Placenta, where it is located, also is very different because what if the placenta is down here by the baby's head? What do you think the problem could be if we have a placenta down here?
It's gonna block the birth canal.
Exactly. And once that placenta gets hurt, the baby's hurt. Because remember, our placenta is what the baby gets nutrition from, breathes from, everything. Okay. So, and then we talk about psych, and this is very important, and we'll do some work on pain medicine tonight to talk about it. But, you know, it's really the mother's psych, like her brain, okay, is going to have an impact on how the labor process goes. What do you think past trauma is going to have anything to do with this? What kind of past trauma could you think of would interrupt the labor process for a mother?
Maybe if she had a bad delivery, like if she had a previous delivery and now she's scared like to go through with this one.
Good. She could have had a past bad delivery. What else could have happened to her that would cause trauma regarding having something pushed out of their vaginal area?
Like if she was torn or something and she had to have surgery.
Okay, if she had something down there that had to be repaired previously, what else?
If she's a rape victim.
Of course. Think about anyone who, or not even a rape victim, but if they had been inappropriately anything, right? They're gonna have trauma with that. Maybe culturally, they don't think that intercourse is a thing to do. You know, there's some religions and cultures that use it sort of as a reward system. So then there's gonna be trauma with that. Do we look at social support here? We have families and doulas. And doulas, anyone know what a doula is?
Is there someone that like supports them after the pregnancy?
So they actually support them during the labor and
yeah.
delivery process. So they're not usually nurses. They're usually people that study giving birth. So they'll do a lot of things with them holistically, like a lot of breathing, bouncing, upside down positions, things like that. So a doula is someone that if you're in the labor room and you're the nurse, you're responsible, but the doula kind of tells the person how to deal with like the pain and how to deal with the labor process. So, but be very careful because doulas are not usually registered nurses. And even if they are, that's your patient. All right. So we look at signs, and I love this picture because the little foot, right? Signs of things that's going to be, oh, labor's coming. Okay. So rupture of membranes, we talked about that. They'll have blood coming out of the vaginal mucus will be bloody. Cervical changes, weight loss. That's a rare one, but so we're going to monitor labor, and this is where I'm going to close this here, and we're going to do a little activity here. And you guys are going to tell me about the 4 different stages of labor. So I came up with a Word document. You guys are going to do this in groups. So there's 4 different phases of labor. You're going to figure out based on your group which phase you have. There's 3 things about each phase that you should know about and where the complications come in with them, okay? So I'm gonna share this Word document in our chat. I can figure out how to attach it. Hold on. I did this last time. Why can't I find out how to attach? All right, I'll just send it through your email, through our Canvas email. So, and you guys are all going to describe this. This will only take you about 5-10 minutes, right? But we know there's 4 different phases of labor, and it's important to know which phase your patient's in because your nursing care is going to be very, very different. So you guys are going to fill out this little sheet for us all, and we're going to make sure that we understand the 4 different phases. You can even find pictures online if you want to make it really interesting for everybody. And sending it to you guys via email. And this is what it's going to look like. I'll pull it up for you and share with you. Okay, so you're going to get this in your email. And you guys are going to fill this out on the document. You're going to identify each phase. Now, group 1 starts with this. That does not mean that's phase 1. Okay, and then we go down. Come on. Here's another phase. Here. Here's another phase. Here. And here's the 4th phase, which is not the 4th phase, but it is one of the phases. Okay, so you guys are going to work on that together. And you're going to explain the different phases and 3 components of each and complications that can come up. Okay, so let's break you guys out into breakout rooms. And then you guys will do that. Okay, group 1, do the first one. Group 2, do the second page. 3, third page. 4, fourth page. Okay. It's all in your book if you don't know the answers, okay? All right, go for it. Jalea, are you there, Washington? Hello? You're there. You see you're in group 4?
I can't get in. Every time I go, it sends me back here.
Oh, really? I knew you were here because I saw you in the classroom. You're in there. All right, hold on. Move to... I'll put you in room 3, and then I'm going to move you back to 4, so hold on.
Okay. Press join or no?
All right,
Okay,
try
I
now.
see.
Join 4. No, you're not going. All right, let me put you in room 4, okay, or 3, okay? Can you join, Jalea?
I don't know what's going on.
I just
I
put you
can-
in 3. Can you join 3?
Let's see. I don't see it to come up yet.
All right, I'm moving you to 4 again.
Okay.
No, you must be doing something wrong on your end. Because you're moving on my end, but you're not moving on your end.
I don't know. Can I leave and then try to come back? Like leave the whole Zoom, then try to come back? Okay.
Yeah, just log off and then come back on.
Okay.
Right, I just assigned you. Let's see if you can get on there.
I don't know.
Just work on one of them yourself then.
Okay, because I'm about to try to join on my phone. I don't know what's going on.
Yeah, I don't know what's wrong because you're the only one that can't join. And on my end, I keep seeing you joining, like you're there.
Right.
Like,
Yeah,
so
but
I don't know what's going on.
I don't know either. I'm gonna try to join on my phone.
Okay, see if you can. If not, just find one phase that you like and look
Okay.
that up.
Okay, let's see.
Recording in progress.
Oh, wait. Okay. Okay, now let's see.
Professor? Hey, Jalea, do you know what we're supposed to?
She had us in groups. Mine wouldn't go in a group though, so she told me to pick one, and just do it on my own.
Because my computer keeps my computer keeps
Yeah, it's going in and out whenever you talk.
What did she say she wanted us to do?
That thing she said with the four stages of labor, she said, pick one and tell what stage it is and what could happen and everything in that stage. So just pick one of the four.
Where did you find that? The 4 stages of labor. Where is it at?
They emailed it to us on Canvas.
Okay.
All right, we're closing all rooms, so everybody's coming back together.
Natalie, is that your baby?
Oh my God. Bless you.
It kind of sounded like a nursery school. I wasn't really sure.
It sounds like in the living room.
That's good. A little kid entertainment's always good, right? They say the best things anyway. All right, so we did this. Very good. You guys did awesome on this. One of the groups was very resourceful, and they used the PowerPoint in their resources. So they knew exactly the questions when I asked. They had the answers for me. All right, who did the first phase? First phase, I will tell you, is going to be the longest phase when you're a labor and delivery nurse. Who did the first phase?
We did.
You did. Who's we did?
We did.
Mercy, you guys did. Tell us everything you learned about the first phase.
So it begins with the onset of the contractions and it ends with the full dilation and the effacement of the baby.
Okay.
There's 3 phases within our first stage.
Good. What are they?
The
Latent.
early, which is also the latent phase, the active phase, and the transition phase.
Excellent. And what's the difference between those phases?
The amount that the cervix is dilating.
Great. The amount the cervix is dilated. And we're going to look at a picture in a second about dilation and effacement. One of the groups was asking, and I think it's a valid point. How do you even know if somebody's dilated or if anything, right? What we talked about is that that's a vaginal exam. And so doctors and nurses do them all the time. Okay. And so I want to show you this picture because it'll really give you like a clear vision of it, what it looks like. So hold on one second. I'm going to share that with you. Okay. Here's the picture. Don't worry, it's not too graphic, but here's the picture. Okay. So here's here's the baby's head and here's the vaginal area. Okay. This is where your pelvic area here. Okay. So when you're not effaced, right, this is like closed here by the head. And then you get a little more effaced, which look at the difference between this and this. Can everybody see the difference? What's happening is this is getting shorter. The head is getting further down. Okay. And then here, it's so much thin that you can barely even feel it. Feels like tissue paper. Okay. And then here's when it starts to dilate. See what happens around the head? It spreads apart. Okay. So here's 3 centimeters. Now this is a very bad photo. And the reason for that is not 3 centimeters. 3 centimeters is if you took your hands and went about like that. Okay. That's about 3
So what,
centimeters.
that's about 7 right there?
So 8. This one right here is about 8.
Okay.
But look how much of the head is almost
Yeah, that's wide open.
Wide enough for the head. Okay. So that's really those pictures. Let me see. I think I have another one. Oh no, I have a practice page. Okay. Now we're going to look again. Here's our second phase. This was the PowerPoint that we talked about. But anyway, second phase, that was a good group. You tell me what you guys figured out about this second stage.
We also had 3 stages in our stage.
Good.
3 phases in our stage.
Mhm.
And that was the pushing, the crowning, and the actual birth.
Okay, so you had the time before, which is called the latent phase. So that's really right as the baby's coming through the birth canal, but not ready to come out yet, right? And then you have that second one where you're going to push and push and push. And then you have that third part where the head's coming. Okay, good. What else? Where could we have complications during this phase?
During stage 2.
Okay, why? You're right, but why?
The inability to actually push.
Yeah.
All right, so if you can't push, if you have one of those conditions we talked about, you're not at second stage because they won't even let you get there. It
What
won't
if,
even be
like,
at the
the
beginning
baby
of your
is
stage.
stuck or
But
something?
good point. But where can some complications come in when you're trying to push your baby out? What could happen? So
The
this
feeding
doesn't work.
Could breathing be altered?
No, because remember the baby's not breathing yet.
Oh, okay.
That placenta is breathing for it.
The cord could wrap around the baby's neck.
Good. As you're pushing, remember there's a cord from the placenta, right? If you push and the cord's around the neck, whoop.
What about coming out feet first? Like, would that be an issue?
So they wouldn't be at second stage, but very good. If they were breech, they would have had a section already. They wouldn't even let them labor. What else can happen other than the cord around the neck? Because that happens often.
The baby can get stuck.
Good. Why would the baby get stuck?
Head might be too big.
Yep. Head might be too big. What else?
If your contractions aren't strong enough, you might not
may
move
not.
far enough.
Well, by our second stage, they're strong enough because they've gotten you to 10 centimeters. So the contractions get you to the dilation and the effacement. So usually by second phase, your contractions are good. They're adequate. Because when contractions aren't adequate, that's in stage 1. And that's when it gets stagnant. Like you'll stay 3 centimeters for 4 hours. Right? Then you got to kick it in and be like, give them some Pitocin, give them some meds to get those contractions stronger. What else can happen though in that second stage? These are really important things. Somebody said a head too big. What else could go wrong?
A shoulder.
Excellent. A shoulder.
Shoulders.
Think about when the head comes out, and I want you guys to think about this very seriously. The head is coming down, okay? It can either face one of 2 ways. Either around, right back of the head, or sunny side up, it's called, the face. Which do you think is easier to come out? Around or sunny side up?
Around, no? Isn't sunny side up harder?
Yeah, because it gets stuck
spine?
on the nose, right?
Mhm.
Think about it. You're pushing, it gets stuck on the nose, and then you got to get past the nose, and then you got to get past the chin. So sunny side up is what it's called. You can reposition a patient and try to alter the way the head is facing. Sometimes it's LOP, ROP, which is our occipital parts of our head, remember? Those pieces. So maybe it's a wrong presenting part. Okay, so there's a lot of complications of second stage. How long do you think second stage can go for?
Well, I found that it said anywhere from 30 minutes to several hours.
Good. And I like that answer. Several hours. It's up to the patient. It's up to the doctor. It's up to the baby. If the baby looks good on the fetal heart strip, you can push forever. What happens though if you push past like maybe 2.5 hours? What do you think happens to the mother?
Exhausted.
She's exhausted. She's like done, ready, over. By 2.5 to 3 hours, you should have had a baby vaginally if you're going to have it vaginally. But what some nurses like to do is push it and say, let's keep trying, keep trying. But I always want you guys to keep in mind the patient, both patients, that baby and that mom. If the mom's tired, that's her right to be tired. So we respect it and we tell the doctor she's wiped, she's done. Blah,
And
blah.
that's what I was gonna say too, is that it doesn't just affect the mother, it can put the baby in distress as well.
Right. And we're going to do fetal heart monitoring in just a second. And this is a big piece of it too. All right, our third stage, what happens here?
It's when the placenta comes out. So it starts at the end of the baby being born and then finishes once the placenta comes out.
Good. What do you always have to do when the baby comes out to do something to the cord? What do you have to do to the cord when the baby comes out?
Cut it after the baby.
All right. So
Oh.
if you cut it, what would happen?
It stops blood flow.
Right. It's going to
baby.
stop blood flow. But what's going to happen is that placenta is going to bleed all over and the baby's going to
Mhm.
bleed what's called bleed out because
Yeah.
that cord is their vessels, right? So think about what do you have to do when the baby comes out and it's still connected to the placenta?
Is
You
it
do
like
have to cut it because you have to separate the two. What do you have to do before you cut it?
You clamp it.
Excellent. You clamp it. So you clamp it in two spots. You clamp it by the baby, right? And then you clamp it at the placenta end of the placenta so that you can cut in between the two clamps, right? Just what that does is it keeps the blood inside the baby and keeps the blood inside the placenta. All right. Now then you got to get the placenta out. So same kind of thing. Placenta comes out like a baby. You push it out. Okay. What can happen during this period though?
She can hemorrhage.
Good. And why would she hemorrhage?
Maybe
Maybe,
because
maybe there was like I don't know if this is dumb, like
it doesn't contract
maybe the
after
placenta
delivery.
wasn't ready. Yeah, I don't know.
Good. Sometimes it's called retained placenta. So the placenta doesn't want to come out. That could also, the placenta could be connected to something else, some vessel somewhere, because placentas grab onto wherever they can. So there might be a problem with that. You will see postpartum hemorrhaging. You're going to see it. You'll see it in labor and delivery. You'll see it on postpartum. What ends up happening, sometimes the uterus now has been an enormous thing, right? Full of a baby, full of a placenta. Placenta comes out, baby comes out. Well, now you're expecting this muscle to just go back, contract back to its size. So sometimes the uterus is like, no, not doing it. I've done this once, I'm good, right? So that's what happens. All right, good. So, and some signs of complications, or problems would be excessive blood loss. We're going to see what happened to the vital signs if they're bleeding.
blood pressure drops,
Increase
Good. Blood pressure drops. What happens to the heart rate?
increases?
Increases because trying to help, right? So what kind of things are we going to do if we have blood loss happening? What can we do to sort of help in the meantime?
Try to stop the bleeding, administer blood.
Yeah. So you're not going to be administering blood unless it's a big blood loss. There's always about a 600 cc blood loss when you have any vaginal delivery. It's when you get to like 1,000 where we get uncomfortable. All right. And then sometimes uterus can act all funny. All right. Then our final phase, which is a good phase, even though it's the final one. What are we going to do? This is where our postpartum nurses come. Go for it. Who did the fourth phase?
Assess the fundus.
Okay. What's the fundus? I'm not putting you on the spot. Anybody can help her out. What's the fundus?
I'm not sure exactly what it is, but when I did my clinical, I was on postpartum and it was like in the belly part and they push it to make sure that it was firm and that it wasn't boggy. And they said as long as it was firm, that was a good thing, a good indication of healing.
Excellent. Fundus is the top of the uterus. So when you're feeling that hard thing, that's the uterus. So if it's not hard, the uterus is mushy, you don't want that, right? So that's exactly what you saw in clinical. Excellent. I'm glad you saw that. So you assess it and it should be going down. As you deliver, the more days you go on, it should go down, right? Because it's shrinking, shrinking, shrinking back down. It contracts back down. Okay, good. Post-anesthesia recovery. What do you think that has to do with? Who's going to have post-anesthesia recovery?
C-section.
So what's that look like?
Getting up, walking, moving.
All right, but post-anesthesia recovery, what are we going to be doing? This is post-recovery, period, even on med surge. What kind of things do we do in there? What do we watch for?
Monitor vitals.
You have to watch for
It says mental status.
oxygenation.
Watch for what did you say? Kelly, you said something. I didn't hear what you said.
Oxygen.
Yeah, you're going to put a pulse ox on your patient. You're going to put an EKG leads. You're going to do EKG on the patient. Now, at this point, the baby's out, so you don't have to worry about the baby. The baby's gone to the newborn nursery or is with the mom, and hopefully breathing and doing what he's supposed to do or she's supposed to do. Sometimes they don't, but you know, that's what we hope for. So this is really taking care of the mom postpartum. You have to watch for bleeding because if they're in post anesthesia after a C-section, that's abdominal surgery. What could go wrong with any surgery? Doesn't have to be abdominal. It can be any surgery. You guys, I want you to think about med surg. What could go wrong with any surgery?
Hemorrhaging?
Good. They can
Bleeding.
hemorrhage.
Yeah.
You will want to watch where she was cut at for like womb infection because that could be bad. Could you become
Or maybe the wound wasn't sealed enough.
yeah.
Right? So they either staple or they suture. Depends on the surgeon. And sometimes they'll do Dermabond with whatever they do, but sometimes it's not sealed. So they actually have at their incision site, it's not closed. So they'll be bleeding from the incision. All right, you want to make sure that you have what coming out in their catheter?
Urine.
Yep, because we want to make sure that the bladder's still working because remember they've had anesthesia. So this should be working because it has a tube in it. But sometimes the body says, oh no, I'm going to cause a ruckus. Sometimes I want you to think about this in a C-section. They make, it's called nick the bladder. So they're cutting the uterus, which is right above the bladder. So what happens sometimes is they'll nick the bladder. So they cut, and instead of cutting just the uterus, they cut both. Okay. What do you think happens if they cut the bladder?
Your urine's going to leak internally?
It could set up infection.
Tons of infection. And your bladder has to get fixed immediately. So they'll call a general surgeon in oftentimes to repair the bladder. Or a bladder surgeon. I mean, depending on the hospital you're in. All right, it's very important during this phase, we look at that newborn relationships and bonding, right? Because this is going to be key. Or is the mom going to know what to do? Is she acting like she doesn't know how to hold the baby? Does she want to breastfeed? Does she want to bottle feed? All this stuff, okay? And so we say the most important nursing action phase in this is assessing for blood loss, okay? So these are our stages of labor. We looked at effacement and dilation. Here's that lovely picture. We're not going to go over our review question. Let's see here. Okay. Next thing we're going to do is fetal heart monitoring. So what I want you guys to do is I have a little video. The video is not one that we have posted, but I really like the guy who does the video. He's kind of funny. So let's watch that video together. And then we're going to play a game, okay? And we're going to go over what a fetal heart should look like. If you were looking at a fetal heart rate, what are some things that you would want to know? If you were looking at anybody's heart rate, what's something you would want to know?
The baseline. A baseline.
Excellent. The baseline. Good. Because if we know the baseline of something, then we know if it's up or down. Right? So we want to know baseline. What else do we want to see on a heart monitor?
Would it be rhythm? Rate and rhythm?
The rate, which is our baseline. Good. You're not going to know rhythm from looking at a strip. A strip is really just a piece of paper. So it's very cool, actually, the way you get fetal heart monitoring. Does anyone know how you do it? You just put a little ultrasound gel on an ultrasound and stick it on the belly. And it'll get the fetal heart rate. So you're not going to see like like on an EKG, you have the different parts of the heart rate. You're not going to see that, but this is what we're going to look at. All right, let's look at our video with this guy. I mean, I know you guys are super excited, but it's very important. Fetal heart monitoring is a huge piece of labor and delivery. Well done. Safeway wants me to watch a commercial. Okay, skip. Okay, let's share the screen with you.
Crucial skill that you'll need in labor and delivery. We're talking about interpreting fetal heart rate patterns. We'll be exploring VealChop Mnemonic, a powerful tool that'll help you understand what's happening with your tiny patients during labor. So let's get started. First, let's talk about why we monitor fetal heart rates. It's all about ensuring the baby is getting enough oxygen during labor. You see, a normal fetal heart rate ranges between 110 to 160 beats per minute, with some natural variations. Monitoring can be done externally using an ultrasound, or it can be done internally with a thin wire attached to the baby's scalp. By tracking these patterns, we can make informed decisions about potential interventions while also avoiding unnecessary treatments. Now, let's break down our star mnemonic, VealChop. Each letter pair represents a type of heart change and its potential cause. So V is for variable decelerations, E is for early decelerations, A is for accelerations, and L is for late decels or decelerations. Now let's explore each one in detail. So VEAL stands for variable decelerations, often caused by cord compression.
Okay, I'm
These
gonna
are
stop this
unpredictable
video
dro-
just for a second and show you here. Here is our contraction monitor. They look like little mountains. Here's the fetal heart rate. So when they say decels, everybody see this heart rate is like running right about here. So we have these little dips, right? And so those are called variable decels. So those are for different reasons.
Drops in the heart rate that could indicate the baby's blood supply is limited due to the umbilical cord issues. Possible causes include the mother and baby positioning, knots or entanglement of that actual cord, low amniotic fluid, uterine rupture, and even cord prolapse. Management might involve repositioning the mother, administering IV fluids, or giving oxygen, or even preparing for a potential C-section. Now moving on to E. E is for early decelerations, typically due to head compression. These occur when the heart rate slows progressively before contraction peaks. It's common in late labor as the baby descends through the birth canal. While it's usually not harmful, changing the mother's position can help alleviate pressure and improve oxygen flow. Now what about A? A stands for accelerations, which are generally okay. These are temporary increases in the heart rate of 15 beats per minute or more, lasting at least 15 seconds. Now these are good signs, indicating the baby is getting enough oxygen. So if accelerations aren't happening naturally, we might try to trigger them by gently rocking the mother's abdomen or using sound stimulation. Now moving on to L. This represents late decels or decelerations, often due to placental insufficiency. This is the most concerning pattern where the heart rate decreases with those decels after contraction for 30 seconds or more. It suggests that the baby might not be getting enough oxygen through the placenta. So immediate interventions might include repositioning the mother, providing oxygen, or preparing for an emergency C-section if the issue persists. So understanding these patterns is crucial for providing safe care during labor and delivery. The VealChop mnemonic gives you a quick way to recall different heart rate changes and their potential causes.
All right, so that was a quick video, but it gave you an idea. So when you're in a patient's laboring, you monitor the contractions. And what you look for in the fetal heart strip is you either look for what's a good sign in the fetal heart strip that he just said.
Acceleration.
Excellent. The heart rate
Acceleration.
goes. Yep, heart rate goes up. That means they got good oxygen. They're good to go. When you look at, there's 3 different types of heart rates that go down. One is like kind of fine, not a big deal. And that's those early ones because they're happening with the contraction. So what's happening is the head's getting squeezed. So think about if you squeezed your head. I mean, your head's much harder than a baby's, but think if your head was soft and you squeezed it, right? You get a little less oxygen to the brain, right? So that's, I like you to think of that, like, oops, no wonder. And then you have those ones that are variable, so they can be lots of different reasons. And then you have the ones that are late, and those are the ones that we'll call for a section. Okay, so we're going to take a look at some strips. We're going to go over them, and we're going to really be very proficient. What I'll tell you about fetal heart monitoring is it's so important in labor and delivery that you get certified in electronic fetal monitoring. It's a whole long class that you have to take. So just something to think about. All right, let's look at our fetal heart monitoring. I know it's a lot of information tonight, and unfortunately, it's a lot of information that we need to know for the test, but it's a lot of really detailed information about labor and delivery and the process. And that's a big part of maternal healthcare, is taking care of that. So that's why we're spending so much time on it. But alrighty, let's look at our game we're going to play here. Any questions on fetal heart monitoring? It's very important. So I want to emphasize that. It really tells us how the baby's doing. That's what it does. So we always want to know that. Because that's the only way we would know. The baby can't say to us, hey, I don't feel good. Uh-oh, something's not right in here. I'm not getting enough oxygen, right? We know that that can't happen. So that's why we have to be really specific. Okay, so we're going to start our little game. Now, this is a resource that you guys have available to you, but let's play the first one. All right, we're all nurses. All right, here's how the tracing comes out. So when you put it on the monitor, this is what it looks like. All right, so I want everybody in the chat to tell me, does this baseline look normal? Does it look too fast? Does it look too slow? Let's see what we think here. Too slow. Okay. Somebody said late. I don't know what that means, but slow. Doesn't look normal. Good. I like you said it doesn't look normal because it doesn't. So it's not too slow, because what's the average range for fetal heart rate?
110 to 160.
Good. And so if I'm going to pause it right here so we can look at it. Do you guys see there's 150, there's 160. So it's within range. It's a normal, the baseline's normal. If you had to look at, what do you think, like looking at this strip, where would you say the baseline is? Like what value would you give it? Like a number.
150.
All right, 150, 155. Either of those are good, right? Okay. And so then it says variability. That means is it squiggly? Like really squiggly? No, it's pretty flat. Does everybody see how flat it is? Okay. Do we see any accelerations where it goes up for 15 beats for 15 seconds? Does anybody see it going up for 15 beats for 15 seconds?
No.
Nope. So we don't have any accelerations. Do we see any decelerations where it goes down?
Yes.
Okay, where do you see
Yes.
that deceleration?
It dropped down to like one, went from 150 to like 130.
Good. And where is that following? It's following our second contraction, right? So he's talking about right here. Okay, does everybody see how it goes from like 150 down to like whoop, whoop? And I can tell you just by the shape of this what kind of decel it is, but we're not going to get into that. Okay, so yes, we do have decels present. Now, if they were early, they'd line up with the contraction. Okay, so not early. If they're late, they're at the end of the contraction. Let's keep looking and see where our decels keep going. So we have that one. Oh, here comes another one. Does everybody see where that decel happens? It happens after the contraction's over. Okay, so we know it's not head compression. We know it's not cord compression necessarily. I mean, it could be. After the contraction, then the cord got stuck. So we're going to call these, don't worry about the deceleration, but this is an abnormal tracing. I will tell you that much. And then contractions are normal frequency. Okay, let's look at our next one. All right, so looking at our tracing, what's our baseline?
$150.
150 is up here. Somebody else help him out. That's 150 right there. So it's not 150. It's really in between 150 and 140. So what could we average that to be?
145.
Excellent. 145. Do we have that variability? Do we have like up and down and a lot going on? No, I'll tell you we don't. Do we have any accelerations where it goes up by 15 for more than 15?
No.
No.
Okay, well, so now I'm surprised you guys didn't pull this one here, but this is only up to about 150, and it's never an acceleration when it's off of a decel. So, no. And then we have our decels. What's happening is every time this lady has a contraction, the baby's heart rate goes all the way down and then tries to recover. And then they have another contraction, same thing again. So these are going to be usually variable, but okay, we'll do this and then. Our TOCO looks good. What that means, adjust TOCO, I'll show you in a minute. All right, let's take a look at this strip. Let's see if this is a better one. Oh, this is so lame, this one too. All right, let's just do this one quickly. What's the heart rate here? What's our baseline? And now this is a 32 weeker. So not so unusual on a 32 weeker. They're not going to have the same kind of strip a full termer would have. But what kind of baseline do we have here? What's our number?
It looks like 130.
All right, so here's 120, here's 130, here's 140, here's 150. What do you think? Where does the heart rate stay for most of it?
Looks like around 150, like a little bit above it, but not really that much.
Excellent. So it's in between 150 and 160. Now the lines are very small, and this is true on the tracings. So 150 to 160. So what's halfway in between 150 and 160?
155.
155.
Good. So we'd have a normal baseline because it's 155, right? And then our variability is minimal. We don't have a lot of squiggle. Do we have any accelerations?
No.
Nope. We have decelerations. And I can tell you that's a variable just by the shape. And so it's probably indeterminate. And then I'm trying to get you to one that looks good, a good strip. They keep giving me all these yucky ones. This is another one. I just want you to look at this strip here. So here we're looking at, remember, with this monitoring, we look at fetal heart rate and we look at contractions. Do you notice anything wrong with what's going on here?
There's some variables going on.
Okay, so there's no variables because variables are decels, remember? So that means the heart rate goes down. What do you see that looks like might be a problem here?
The contractions are really close.
Excellent. So you're not resting. They're not resting because a contraction should look like whoop, and then you have some time. And then another one and zoop. The other thing I don't like about this tracing is you'd have to adjust that TOCO. So the TOCO is what monitors the contractions, and sometimes you have to put it in a different spot. The hardest part of the belly is where you put the TOCO. So you might have to adjust the TOCO in this one. That's where they ask you about more data needed. We'd need more data on this one. This is a 39-weeker. What else could be happening here? He's having no accels. Could mean also he's sleeping. So sometimes when babies sleep, they'll look very flat like that. And then when they wake up, they're fine. So you want to like tap the belly or, try to wake it up a little bit. Okay. So that's important. All right. So those were some fetal heart strips to look at. So that's what they look at if you're in labor and delivery. So I want you guys to be familiar with that. There's the EFM game, which is on your resources. So that's good. All right. And then we have, with the labor process, we didn't talk about this, but this is very important. What do you think we do for pain?
Labor
Epidural.
pain? Yeah, epidural.
Okay, and sometimes you put medicine through an epidural, which is a line in the back and what else can you do?
Don't they have the gas mask too? Does that
You
help with
can,
pain?
but think about what would happen if you're the mother taking a gas mask.
Is that what it's called though? The mask that they inhale?
Yeah, it's called a gas mask.
Oh.
But sometimes they'll put it on a mother, but whatever the mother takes, the baby gets.
Mm-hmm.
So just be careful with those, okay? And so you guys are going to, I was going to have you guys work together. You want to just do it as a class? We'll go through the different pain management. All right.
Let's do it as class.
Okay. I don't like to talk all the time. I know you guys don't like to hear me talk all the time, so that's why I try to give you guys like some things to do on your own, but sometimes it doesn't work out well, you know? All right, so we have many different things we can do for pain. Pain is going to be a big, big piece of your nursing care because just like any other nursing care, you have to make sure that your patient is comfortable, right? Our point with our pain management. And so epidural is one way. What else while I'm pulling this up? What are some other things you think we could do? Gas mask, you said. How else do we treat pain?
You can give you can give IV pain meds.
Yeah, what kind of IV payments you're gonna give?
Pain med-
Give me some examples of payments you're gonna give.
You can give morphine, but if you give morphine, it's real. You have to give like a really low dose.
Yeah, it's usually 1 milligram. Any of those narcotics though, remember guys, what do you have to make sure before you give a narcotic to a mother? What has to be good? What has to look good?
Blood pressure.
Blood pressure.
The blood pressure.
Nah, I mean, yeah-ish, but not blood pressure. What has to look good before you give a narcotic to a mother?
Oxygen.
Oxygenation.
Ooh.
The make sure the baby's okay.
Yeah, you got to make sure that that fetal heart looks good, has cells, is active, because what a narcotic is going to do to a baby is put it to sleep. Right? So you don't want to put a sleepy baby to sleep. Everybody understand that? So before you do any pain management, you are going to look at that fetal heart strip, okay? All right, now let's see here. We'll pull this up. Here's some non-pharmaceutical stuff that we do. Okay? Somebody want to read through this list quickly?
Counter pressure, back pain.
Okay, so stop right there. What do you think counter pressure back pain? What do you think they do?
When they're putting pressure on the lower back.
Yeah, so not when they're pushing necessarily, but when they're having back pain, you push against the back. Okay? Therapeutic touch, what's that?
Touching like a sense. I don't know.
You're right. You just like therapeutic touch is
Push.
holding their hand.
Don't you push at the bottom of the
Well, all I heard was something about a bottle. Therapeutic touch is just therapeutic touch. It's just doing things that'll be therapeutic. You can do massages. They can rock. They can move around. You can do hot and cold, like get in a shower, get in a bath, right? Do some aromatherapies. Breathing techniques. He, ho, ho. That's what they say. All right. So then we look at our different types of drugs that we give, okay? So any opioids are going to cross the placenta. So what does that do?
Goes to the baby.
Yeah, goes to the baby, so makes the baby depressed too. Okay. This is what you were talking about, the laughing gas, right? So you can self-administer it. It's a rapid onset. Can make you throw up though, terribly. So that's never good, and dizzy. All right, here is the epidural that we just talked about. So they stick a needle in and put a catheter in there. See the catheter? And then the catheter gets continuous fluids through it so that it dulls the pain sensation. We can do blocks, like neuro blocks. They're not used as frequently, but the epidural is the best one because when you are done having labor, you can pull the catheter out and then the medication is done. Okay. And its impact on the baby is very minimal. All right. Sometimes they'll do a block, but could you imagine if you're in pain and then you have to have a needle put in there as a nerve block? Oof, that would hurt. All right. General anesthesia. I wanted to talk about this. This is something that we try very hard not to do. Why do you think that is?
Because it goes to the baby.
Yes, all of that stuff goes to the baby, and the babies can't tolerate a ton, you know? So, other thing that we have is if the patient has not been NPO for 8 hours, they can aspirate, right? That's true for any surgery. It hinders skin to skin. Anybody know what skin to skin is?
Only put the baby directly on your chest after they're born.
Newborn is on the mother.
Yeah, it doesn't have to be on the mother. It could be on the dad too. But yeah, newborn, it's skin to skin. You put the baby on spare skin of yours. All right, they must recover for 1 hour, and they're prone to fall asleep more so post delivery. There are also a huge increase for DVTs because we know that our cardiac system gets a real run for its money. All right, what is a problem that we see with epidural anesthesia?
The-
Does anybody know what happens with anesthesia?
Hypotension.
Yep, blood pressure goes down. Do you know why?
No.
Anybody think about it? Why would their blood pressure go down? Why would blood pressure go down post epidural?
Is it vasodilation?
Excellent. You're gonna have that. How are you gonna fix that?
Mm,
You're gonna push fluids, right?
no. Oh, yeah.
Yep, you're gonna push fluids to help it out, to clump it up a little bit, and you're going to turn them on the left side. Why do you turn them on the left side?
Does it have something to do with the heart?
It has
Circulate
something to do with the
blood.
big vessel, not the heart necessarily, but a big vessel. What vessel?
SBC or no?
Say that again?
SBC.
The vena cava, right? Because it runs down the back and you have this heavy uterus laying on it. You got to shift it to help with blood flow. Does that make sense? You got to shift it to the left. So when you shift it to the left, you want all laboring patients to be left tilted, even if they have general anesthesia. You want them left tilted because then you're not having compression on that vessel. Okay. So that's our pain management for labor and delivery. What else do we have to do tonight? We have, I think that was everything. Postpartum, postpartum. What kinds of things are we going to be looking for? What's our priority as a postpartum nurse? What's our number one assessment?
Depression.
Oh, well, that's one of them.
Emotional distress.
Is it the fundal assessment?
Yeah, bleeding. Making sure they're not bleeding out, right? Okay, hold on. All right, we're gonna play a little a little Kahoot together as well, just to review everything we've done tonight. Don't forget, we have an exam review tonight. I think it's at 6 or so. So we'll review real quickly. What do we need to do before we start the Kahoot? What do we need to do for next week?
The practice exam on Exemplify.
Thank you. What is the passcode?
400101.
Yeah, 01. Yep. 4001. We all have to do that, make sure that our systems are updated. There's not going to be a lot of leeway on that. You need 2 devices. You need your phone and your computer. Computer to take the test, phone for Zoom. There is to be nobody in the room with you. And if you are wearing glasses, I will ask you to take them off and show me both sides for the smart glasses, just to make sure everyone is on track. I'm sorry. Sorry about that. Okay, you'll have 2 devices. You'll have your computer, your phone. There will be no papers allowed around you. You must have a whiteboard if you want to do math. I will tell you right now, there's 5 math problems on every test. So if you're behind on your math, make sure you guys are practicing. Calculate with confidence. Okay. My best suggestion for study techniques is to attend the reviews. Okay. We write the tests as faculty, so we kind of know the topics to focus on. You know what I mean? All right. Any last minute things before you play the Kahoot? No.
Where can we find the topics for the NCLEX questions due this week? I don't see it on the syllabus.
It's not on the syllabus. Let me look.
Oh,
It might be when you click on the actual assignment. Let me see.
I did that and I don't see it there.
No. All right, let's see. Okay, this is your. I didn't put it in the announcement. No. Let me
It's under number 4.
Is it
So
subject?
click on the
Antepartum
and
and-
it tells us to select the antepartum and the interpartum.
I'm
Right under
sorry.
number 4. Under number 4, after you click on it, it'll open it up and then it gives us step by step to do.
Oh, great. Thanks, Mercy. Some of these little details I'm still kind of new with because I usually teach community. And that's a little different because in community, we give you the set questions. So it's a little different in this one. So I apologize for the lack of knowledge on that one. All right, let's do our Kahoot and then we'll be done and then we'll do an exam review. It'll be great. If you guys can attend the exam review, please make sure that you watch them. Dr. Brown does pay attention to who shows up to the exam reviews, just kind of FYI. So just something to think about.
Does the when we join the exam review, can we be in the car then listening?
Well, I'm okay with that. I can't speak to other instructors. So if that helps.
Are they recorded?
I'm fine with I can't have you guys in a car or anything else during during class time. But if you want to listen in the car, I'm okay with that. I mean, I think I'm good with that. I'm always good with that. A lot of times I don't even have people turn on their cameras for the review.
Are the reviews recorded or no?
Uh-huh.
Oh,
And
okay.
I posted some already for you guys.
Okay, I thought so. Thank you.
Yep. All right, here's our lovely
They're all
Kahoot.
the same though, right? The reviews, or they're different? They're all the same, I'm assuming.
Well, no. It's individualized, meaning the professor teaches it the way they want.
Oh, got it. Okay.
So it's not going to be, I mean, that would be silly, wouldn't it? If like 6 of us all said the same thing. So I think that's why we do it that way.
As long as you all cover the topics the same.
Yes, we do all cover the topics. It's just a different deliverance. So if you guys haven't figured out, I really like PowerPoints. So that's how my review will go. But that's not everyone's. And some people are more interactive than others. I try to just get down to business because you guys sit through class. And so I just feel like I'll get you the information. I don't need you to chit chat with us. So, but that's how I teach, but I can't speak for everyone else because I really don't know. I don't go to their reviews. And I find it most helpful. Feedback from students is that I give what they need to know. So, which is helpful because it's a lot. It's a ton of information to come at you guys. All right, here we go. A lovely thing. Sharing our Zoom. All right, there's your pen or your QR code, whatever you want. Just want to add in here as well, if anybody wants to review one-to-one, feel free to just email me and I will schedule a time to do that before the test. Please make sure you're on time next week as well, because we start that test on time. So you guys got to be here on time. All right, we ready? Let's start. The nurse is caring for a laboring client. Which statement indicates the client's in entering stage 2 of labor? Oh, a lot of you like that one. I was afraid of that. All right, remember, second stage of labor is fully dilated till the baby comes out. You will have people who are not even dilated say, I feel the baby's coming, because the baby's head sits on that area and puts pressure. So saying the baby's coming now doesn't really mean anything. I feel like I have to push down. That's how you know they're fully dilated. The head is sitting there. They're ready to go. Okay. The baby moving a lot, you would hope that's all stages. And water broke, that means nothing because they may not even be dilated yet. Okay. All right. Next one. Here we go. Blood pressure drops after the epidural, like we just talked about. What's our priority? Hey, yay! At least some of us were listening. Good, good, good. You're gonna always reposition to the left and give a fluid bolus. When would you notify the healthcare provider?
After that doesn't work.
Yeah.
Exactly. If that doesn't work, good. All right. Some of these questions are not hard. They're just think about it. Teaching a pregnant client about fetal growth and development. This we didn't really talk too much about, but I want you to know about this. Excellent. Good work. And we didn't even go over this. This is very important. Why do we care if the baby's gaining weight?
For growth.
Why
and
is that a
development.
priority?
Because they're getting the nutrients they need.
Yeah, they're getting everything they need. If they're not growing, then something's awry, right? All right, let's look at our next one. Oh, I'll skip this because we didn't go over this. I'll skip this one. All right, providing care to a client at term with heart disease. Which focused assessments will the nurse include? Oh, excellent. You guys did great on this. We didn't really talk much about cardiac, but why are we going to worry about these things? What are they suggestive of?
Heart failure.
Say that again.
Heart failure?
Yeah, the heart's not working good. It's not pumping stuff out, right? We're having chest pain. We're having extra fluid hang around. Good. Shortness of breath. All those have to be included. Excellent. All right. Teaching fetal circulation with the client. The client understands what statement is true. Oh, we didn't really go over this. So let's skip it. All right. I've been leaking fluid for about 2 days now. I thought it was urine. Now I'm not sure. What is a nurse going to do? Think about it. She thinks she's leaking fluid. How's the only way we can figure that out? Oh, interesting. I don't know why we thought. Tell me what you're thinking. If someone's leaking fluid, why would we care about our vital signs? Nobody wants to say.
Maybe if they lose too much fluid, their blood pressure would change.
Okay, I would, if I were answering this question, I would answer green and red. Why would we obtain an ultrasound?
To see
if there's any fluid around the baby.
Good. You have to see if there's any fluid. So, I mean, you would assess maternal vital signs because you always do. But I would also do an ultrasound because you can see how much fluid's in there. So you'll know, is it urine or is it fluid? There's also a little a test that you do. It's with litmus paper. It'll turn blue if it's amniotic fluid. If it's urine, it stays yellow. So that's a lot of times how we test for it too.
Before you give the next question, do you care? I thought we end at 7:45. Do you care if I take like a 10-minute break so I can make the exam?
No, but you know what I'm going to do is I'm actually going to stop here. Thank you. But it's we do go till 8:11, which is 10:11. But I told you guys I would give you out early, so I was gonna just give you out. But if you guys are like over it and done and ready to go, let's do that because we have exam review at 6 and 8 o'clock. God, I'm so confused by time. Yeah, 8 o'clock your time. So I'll give you the 10 minutes beforehand so that I can actually stop talking and you guys can stop listening to me. All right.
Same chat. It's in the same Zoom chat, right?
Yeah, same Zoom.
Oh,
I'm
okay.
gonna end our session though, okay? So Lisa, I know you just joined on for review, but I'm gonna end our class and then restart. Okay?
Okay.
All right, hope to see everybody. Good luck. Send me an email if you want to study. What else can I tell you?
What's your email? Because I actually am interested in a one-on-one session.
Yeah, I'll just put it in the chat.
Thank
Don't
you.
forget, all my contact info is
In the
under
syllabus, that's
about your
right.
no, it's under about your instructor in
Okay.
Canvas. But it's
Okay.
okay.
Thank you.
You're welcome. Okay. So everybody, we'll see you for review or we won't, whatever. Just let me know either way. Okay. Take care. Have a good night. Stay safe. Stay healthy. I will see you guys next week.
Why is it doing that? Oh.
Sorry, Lisa, I'm ending and restarting.
Okay. All right. I'll come back in.
Yeah.